Good afternoon. Yeah, my name is Dr. Clifford Porter. I'm the Healthcare Policy Director at Texas Public Policy Foundation, whom I represent. I'm also a practicing physician locally, representing myself in my clinic, Texas Direct Medical Care, also using the direct primary care model. So invited to provide context to the rising costs in healthcare and some options TPPF is proposing. A lot of my initial preamble, everyone else stole the thunder, so I'll skip over a bit. But the healthcare, just as I say, it's a case study in all the negative consequences of market consolidation, anti-competitive practice, and all these layers of middlemen and bureaucracies. And the first two slides you've probably seen in everyone else's slide deck as well. But slide 4 shows the massive growth in the administrative burden that's causing a lot of these conditions and is affected by it. Prior authorizations, claims denials, network restrictions, clawbacks, another one just spoken. So clinics have to go faster and faster for billing demands, whether it's government or private sector, and see as many people as possible. It's kind of like a sped-up assembly line. So bad medical practice leads to bad medical care, and we've all seen that in various ways. So slide 5 shows we have the worst health care, twice the cost. But slides 7 and 8 show so a lot of the market consolidation, how hospitals and insurance corporations and all their various efforts, they generate multiple revenue in different ways, and this is all by market control. So ultimately, we work for who pays us, and doctors work de facto for insurance companies, essentially. So insurance and investors are dictating medical care. So patients are held hostage to their own health, and physicians no longer work for the patient. So. But there's better ways, I like to say, especially in direct primary care. But so individual control with health care coverage options can really bypass this convoluted system. So slide 9 shows actually some other actuary data from direct primary care savings as well. So just to show you that cash prices can actually do a lot, and it's achievable right now. Dr. Smith discussed some already, but X-rays, I can get cash price for $50, $60, whereas I had one of my patients spend $110 just on the copay at the same facility, which charges $63 for the same X-ray, and they refused to allow it, saying she had to use her insurance, and they could prosecute her if she didn't admit she had insurance, which is just nonsense, but that's things that occur. MRIs, $300 to $400 cash price versus $1,000 to $2,000 if they haven't met their deductible yet. So recently we did an op-ed, a pair of EpiPens is now $300. But if we could change the law, I could do an equivalent of an EpiPen for $5. So common labs are $2 to $3 each. All the guys want to know their testosterone, come see me. That's a $4 test, not a $50 to $100 test. So the costs are dramatically lower when you just get away of all the sort of all the fluff. So what are some of these reform options? So slide 10. So bypassing the restrictions, a lot of ACA can be done at the state level through what are called 1332 waivers, Section 1332 of the Affordable Care Act. So slide 10 shows you on the left the way it is. Subsidies go through insurance, which controls so much of medical care. On the right, it's the way it can be. Subsidies redirected towards individual control with options. And there's a variety of ways we can actually unpack this. So depending what happens at the federal level is how we can adjust what we could do potentially with waivers. So first and importantly is redirecting the subsidies directly to Texas and then into patient-controlled, essentially HSA-like accounts, similar to ICRAs. But it creates a direct marketed individual control, so competition. Slide 11 lays that out a little more clearly. Secondly, and this is restore catastrophic and other flexible plan options, including cost-sharing plans, not just strictly insurance. So expanding these coverage options, giving individuals control, it shifts dramatically how you can actually control health care. You're not having other people tell us what we're doing and how we can actually treat patients or find our own care. Again, it's funding the patient, not these bureaucracies. So those not eligible for subsidies, still can have a Texas HSA-like accounts, and expanding again the cash market. This is critical in rural areas as well because you could bring a different payer to the system. So I have friends who are in rural direct primary care. They're flourishing. They're doing quite well, and you could really change the dynamic. But so much of what we talk about in reforming healthcare is about the billing cycle, So it's really nice being outside of that. I don't have to mess with that at all, as Dr. Smith says. Along with that, in the interest of time, the last slide just listed a couple different types of reforms that would actually supplement all this and do things as a package. So direct drug access to bypass, so essentially insurance control of the supply chain through their PBMs. And there's another group called the GPOs, Group Purchasing Organizations. They take fees off of the drugs before the rebate takes place. So if they say they're doing 100% rebate, they've actually taken off fees through offshore group purchasing organizations that are based in places like Zurich and Dublin, which I'd like to go visit. But so we can get immediate savings in a variety of different these ways allowing it. Individual portability of benefits is another interesting idea other states are looking at and have done trials on, which could work quite well. Individuals can participate in a business's plan without being tied to an employer. So they're not necessarily becoming W-2 employee, like contractors and gig workers. And you can do this outside of strictly ACA plans. And it gives people more options on how they control their costs. So people can have more benefits in small business and individual contractors without having to rely on more subsidies or Medicaid. So prior authorizations and step therapies are a huge part of these administrative burden. Any decision that impacts an individual's medical care should be based on the same medical standards of care. And that's not the way it is right now. That should be changed. Any decision that affects medical care should be the same standards. Insurance companies use a different standard, and it's quite divergent from what the rest of us do practice in medicine. And then additionally, addressing the vertical integration with antitrust actions, I think, has to be done. Antitrust through the courts can take 5 to 10 years. Those of us who are slightly old enough remember AT&T's battle not to be broken up. But by legislative action, we can break these things up. The GPOs, pharmacy benefit managers, they should be divesting of pharmacies because we see what they're doing to the independent pharmacists. There's other forms of this, prior authorizations. There are these third-party administrators who manage prior authorization and claims denials requests. They charge per administrative fee they're doing. They're actually owned by the same insurance companies, so it's just another revenue stream. So that's an antitrust. That's how market consolidation affects these things. Also, you know, ERS and TRS, this is an area of enormous opportunity for savings because they're losing about $500 million a year each. Add HSAs to these. Give people options in ERS, TRS employees in smaller rural communities. Again, you bring a new payer to the system who's controlled. So lastly, looking at all these things, opening up some of these options, and in the interest of time I'll shorten up, giving people more options, essentially people can get their doctor back. Thank you, Madam Chair.